Okay, record. Okay. Okay. Hello, everybody. Let us start this afternoon's seminar, and the title is a clinical approach to a breathless patient. What should we do? Is it okay? Now, this is what I need to emphasize to all of you. Okay, it is very important for a doctor to take the history of the patient. By the history, we mean what is the presenting problem, and then we need to know the story of this presenting problem, presenting complaint. It is like asking an auntie a good story, and very often storytellers are not good. They will say something and then they jump past to present, then you get all confused. So the secret to a good history taking is to be interested in the story and to direct the teller to what you want to know. Knowing the story of the problem, you must go and ask about what is the past problem. You say, I'm sad. Why are you sad? Quarrel with someone. Then you say, who is that someone? Then you say, it's a boy, a man. Then you say, how long have you known the band? All sorts of things. You're going to try and get as deep as you can on the past. And then you want to know about the background, the family, the social background, the medical background. All of this will build up to a good story. Now, after knowing the story, which is very important, you must take 10 minutes on this. For an exam, they will want you to do the whole half an hour or whatever, just taking the story, and they watch you take the story. Then you examine. By examining, it means you use your senses. What do you see? What do you feel? You knock to know whether it's solid. What are the sounds you hear back? And then you use your ears, the stethoscope, the symbol of the medical profession. This is the examination. And then the last part is you think of tests to do. Now, this is a problem with modern medicine. All of us are talking about tests, but unfortunately, it's like talking about the internet. There's so much data. Not every data is useful, nor is it correct. And so you must think of tests that you call for that can change your opinion and the decision you have to make. So you only do tests that are relevant, and you form your opinion after the history and examination. So please remember, every test you do, you must look at the result. You don't do the test because it's there. You do the test to know more and to see what next you have to do and to see whether you're on the right track. And that's very important. So essentially, now, how do I move this away? How do I move this away? I can't move this away. I can't move the top away. Oh dear. Wait. Okay, you see, let me see. Can you tell me how to move the top part here? What do I do to leave? How do I do to leave the top part here? Because it's blocking me a bit. Anyway, for success in medical examination, that's what I want to say. For success, hide video panel. There you go. Oops, no, now I can't see you. Wait, give me a time. Hide floating controls. There you are. Okay, I've got it back. Anyway, I can't see you all now. How do I see you all? Okay. Correct. Now let me see. So show video panel. Okay. Then I got to hide it again. Hide floating control. Okay. So there you are. Now, so for success in the medical examination, this is very important. So you want to get through your exam, you must spend enough time on the history. You must do a good examination, and then you will pass. And then you do investigation to get your distinction, to get a good pass. But this is very important. Now, it's more important than just the medical examination. For your success as a doctor, you must do this. You enjoy doing this, you can be a doctor. You don't enjoy doing this, then there are only certain specialties in medicine you have to pick up. For success in all of these things, you need an inquisitive, you need an organized mind. So essentially, it's like Sherlock Holmes. I don't know if you know, but Sherlock Holmes was written by Arthur Conan Doyle, and Arthur Conan Doyle was a doctor. He was a graduate of Edinburgh University. And after going through the medical curriculum, he was so impressed with his training that he used it on daily life, in crime, and he started writing stories and became very famous for that. So essentially, Sherlock Holmes is the ultimate medical doctor going through the clinical process. So right, now we start. Now someone read. Who is going to read this? Please read these things.
Today,
hello.
Today, Ms. Lim, 60, present in the hospital with shortness of breath, which has been progressive over the past 5 days. She has, however, experienced episodes of shortness of breath during past 4 months, especially when exerting herself. She gets tired easily and has been physically inactive. She also complains of anorexia.
Right. Now, the reason why I ask you to do this is you have got to learn to do this. This is what happens when you are a medical student, when you want to go and sit for an exam. The examiner will expect you to say these things. This is also what happens in daily life as a doctor, because you have to tell your consultant or your senior what the patient is all about. And this is what you do. So you've got to do this, practice until you are very smooth. Then you know how to talk, your voice, when it goes fast, when it goes slow, and things like that. So essentially, you now have a lady who is a bit older and she's breathless. Now, how long has she been breathless? 5 days. But more than these 5 days breathlessness, which is what is very disturbing and brings her to you, what is more, she actually has been breathless for the last 4 months, but she kind of ignored it. Maybe she thinks it's something small. And then this breathlessness is getting worse, progressive, and it is especially bad when she exerts herself. Now, if ever anybody tells you a story that when they try to do more, they cannot, that is something you have to pay attention to. It's like a car. If your car is damaged, the more you try to run it, the faster you run it, that's when you feel it. A tap, if a tap is blocked, spot, you turn it big, it won't flow. So anything that is worse when you try to use it, when you try to do more, is not a good thing. So this is the important thing you picked up. 4 months getting worse, 5 days. Now, besides being breathless, she also gets tired. She cannot be as active as before, and she cannot eat. So what is in your mind at this stage? This is what is in your mind. Anybody who is breathless, you say, is it a lung problem? Is it a heart problem? Or is it a generalized body problem? That means something in the blood, metabolic, renal failure, diabetes, anemia, whatever. Is this, which organ system are you dealing with? This is how you think. You think step by step. Next, someone else? Hello, someone else there? Ganesh, you
Yes,
got 10
doctor.
feet. Who is next?
Last night, she awoke suddenly from sleep because difficulty to breathe and developed a cough. The breathing problem improved when she sat on the edge of her bed for an hour. She generally sleeps with 2, sometimes 3 pillows. She has not experienced chest pain, leg pain, or fainting spells.
Now, see, this is a story that the patient tells you, but as a medical person, this story is very, how you say, striking and has certain technical terms. So when you awake suddenly from sleep, what have you got? You've got paroxysmal nocturnal dyspnea. That means when you go to sleep, you feel quite okay. You're even able to sleep. But 2-3 hours later, you suddenly cannot breathe. This is because when you lie down, the blood flows back to the heart, but the heart is not good, but can still take it. But what happens when you get good sleep? 2 hours later, when you get good sleep, you go into what is called REM sleep. In REM sleep, your heart beats faster. There is sympathetic stimulation. That's why your eyes go into rapid eye motion. And that is when your heart has to work harder. And that is when it cannot take it and fail. So this is classical of paroxysmal nocturnal dyspnea, the first line, see? Then this is what happens. She has to sit up for about an hour before she gets better. Now, PND, paroxysmal nocturnal dyspnea, is very serious. Someone says they get up, cannot sleep, uncomfortable, go for a drink, walk away, come back. That's not PND. A person with PND means the water has gone into the lungs. They are drowning in the water of the lungs, so they are very unwell, desperate. They are very desperate. They'll probably wake up the person sleeping next to them or in the next room. So you must hear PND and know how to ask to find out whether it's PND or not. And then she generally sleeps on 2-3 pillows, is suggestive of autopnea. Now, autopnea is worse than PND because autopnea means the guy cannot lie down at all. See, in PND, they can lie down because the blood flows back, the heart can still take it. Only when the heart is strained in the middle of sleep that it cannot function. For autopnea, even lying down with the blood flowing back to the heart already is so weak, it can't take it. So they get breathless on lying down. That's autopnea. So she sometimes has autopnea. And then there are important negatives. She has no chest pain, leg pain, or fainting spells. Means they are telling you she has no angina. Angina is ischemia. They have no claudication, that's ischemia of the legs. And then fainting spells suggest that there's no serious irregular heartbeat. So what is the problem now hearing this part of the story? It clearly is congestive cardiac failure, mainly left heart failure. Now, left heart failure is when the blood flows back to the heart on the right side, but it's the left heart that cannot pump it out, so it floods the lungs. So this lady has a problem of left heart failure. Next. Oi, hello. You guys listening or not? Can you hear me? Isn't someone supposed to read?
Doctor, I'll read, doctor.
Are you reading? Okay. Then if you are there, someone who is here, anybody can read it, please.
Excuse me, Doctor, I'll read. I think I'll read.
Read.
Okay, so Mrs. Lim has been under your care for a variety of medical problems during the past 6 years. She has been treated for 2 myocardial infarctions, hypertension, and non-insulin dependent diabetes.
Now, what does this mean? This means that this lady is not just 4 months and 5 days. You know, just now we talked about her breathlessness 4 months, and then 5 days she becomes very distressed. That's why she comes to see you. This is a long story already, that for the last 6 years she has not been well. And what is she not well with? She's got 2 heart attacks, she has got high blood pressure, she has got diabetes. This is very important, no? We now have an elderly lady of 60 who has not been well for some time. So this lady has multiple predisposing medical conditions. How did we end the last slide? We ended by saying this problem is cardiac left heart failure. Now, knowing these medical conditions that predispose to cardiac condition tells us definitely this lady is now having heart failure from a cardiac pathology. So we now are able to reach a provisional diagnosis. Now, this is how we think, you know. Every part of the story we hear, we technically assess in our head, what does this mean? We then elaborate it a bit more, form an opinion. Next, is the opinion correct? Next, is the opinion correct? So now we are so clear. Cardiac condition, because there are multiple medical conditions that make the heart no good. And so what's the diagnosis? She has congestive cardiac failure. Now, what causes the congestive cardiac failure? Ischemic heart disease, because she has had previous heart attacks. Heart attacks or myocardial infarctions are severe ischemic heart disease where there is total block of the coronary and there is damage to the heart muscle. And then hypertension and diabetes predisposed to ischemic heart disease and myocardial infarction. So it's it's a full house. We have got it made: congestive cardiac failure, underlying ischemic heart disease. But like all good doctors, we must think at the back of our mind, could it be something else possible? It could be a metabolic condition. That means diabetes, sugar very high, perhaps caused by infection, can make her breathless. And diabetes and hypertension can cause kidney failure with anemia. And so that might cause her breathlessness and her heart failure, actually. So we have now reached a fairly good level of what the problem is. Congestive cardiac failure, underlying ischemic heart disease. Back of our mind must remember uncontrolled diabetes and must remember possible renal failure or anemia. Respiratory is out of the picture. This is how we function for the history. Now, we shall now come to the examination. But at this stage, how many people are there in this group now? Hello, how many people?
249.
Good. You see, if I talk and you listen, it's not going to be successful. So what you do is, if you have questions, please ask. I stop for a while, you can ask. What question? Come, got question or not? They say there's this fellow who finished his Tai Chi class, and then the master said, no, you can now ask question. Then the master said, there is a bell. I'm like a bell. And so you throw stone. You throw small stone, you get small sound. You throw big stone, you get big sound. You don't throw stone, there is no sound. So now you have a chance to meet me, to hear me talk. Now you throw stone. You don't throw stone, you get less out of this session. Yes? We are on computer, so I can't do anything to you. You must be brave to talk. And it's going to be your life in medicine. No? You'll meet a lot of very busy people, and you talk to them, they sometimes talk back, and you have to learn. No? Sometimes you talk, they scold you. But you got to learn how to talk to make them like you. That is unfortunately life. Huh? No questions? Wow. Okay, no questions, I go on. Hey, can I just have a rough idea? What year are you all? Somebody answer lah, right?
So some of them are from year 5, some from year 4, year 3, year 2.
Okay, so very good. Whatever year you are, you can always ask. And then sometimes it's a bit difficult if I say what you don't understand. So, please ask. I graduated in 1983. So you are like me 40 years ago. And you look at the screen, this is what you will be seeing of yourself 40 years from today. So, it's like that. But medicine is much longer than 40 years. It's 4,000 years, So this is an ongoing process. You have to learn by putting in an effort. You sit back and expect it to come, not going to work. Okay, let's do examination. Next, we're going to read. Hello.
Examination in the clinic reveals an undernourished woman who appears depressed and older than her stated age. Her breathing is labored and her lips appear cyanosed. Blood pressure is 98/82 millimeter mercury. Heart rate is 110 per minute and irregular pulse. Respiratory rate is 26 per minute. Temperature is 98 degrees Fahrenheit.
Okay. Now, actually, in the tutorials that I take, I usually let the person answer, but it's, I think, more difficult online. And this is the first time we meet, don't know how it is. So I will give you what I see. So if you see someone who is undernourished, depressed, and looks older than usual, what does that mean? This means the fellow has a long-term problem. This lady cannot have a problem for 5 days, because for 5 days, you cannot be undernourished and you usually not depressed. And then when you're older than what you are, it means usually life has been tough. You're not looked after your physical health. Now, when you see a person labored breathing, of course, it could be a young girl scared, hyperventilating, but gee, the lips are blue. That's not a good sign. That means the body system is not getting enough oxygen. And of course, in heart failure, that will happen. No? In heart failure, the lungs get flooded. The transmission of oxygen from the alveolar cavity, from air to the capillary in the circulation is not good because there's water there, it can't get through. So they become cyanosed, hypoxic. So this lady is sick for a long time. Now, blood pressure about 100/80. She is not desperately sick, but nor is she well, no, because it means blood pressure is actually not quite good. Usually a person who is distressed will have a higher blood pressure. So this lady doesn't look good when she comes with a blood pressure about 100. Either that or she has been on treatment, because all treatments lower blood pressure. So she may be taking some treatment and that's why the blood pressure is like that. No? And of course, the heart rate is 110. Normal is about 70. Again, indicating that she's quite distressed and the pulse is irregular. Now, that's bad news. That you see the show, this Wong Fei Hong, this Chinese physician, they touch your pulse and they know everything. It's quite true, You feel the pulse and it should be regular, it should be slow, it should be strong. A person of a blood pressure with a pulse pressure difference between systolic and diastolic of only about 20 will have a weak pulse. The strong or weak pulse depends on the pulse pressure, difference between systolic and diastolic. And on top of that, it is fast, indicating stress, and then not regular, meaning there's some disease. And you should go and ask and read, and whenever a pulse is irregular, you want to know whether it's irregularly irregular. That means totally irregular, which suggests atrial fibrillation, or is it basically regular with occasional irregularity, which suggests an ectopic, an extra beat. Means basically regular, then on and off you get just one irregular beat. That's indicative of ectopic beat. Okay. Now respiratory rate again 26 is fast. Normal about 18, 15, you know. And then she's febrile. Look, temperature is supposed to be 97, is it? I think so. Maybe mildly febrile. So what does this mean? She is moderately to severely ill. She's not mildly ill. This one, you must move fast. And if you are busy and if you don't know, you better tell nurse, call senior doctor, call someone more senior to help me out, because this lady is not well and has to be done. Something has to be done. You don't have hours. You may have minutes, maybe an hour, but you cannot waste time, spend half a day like that. No good. And you have to wonder, now you say there is heart failure, but is there infection present because of the temperature? Because of the temperature. Now, I think all of you would know of Sherlock Holmes, would know of Netflix. Can you please go and watch this Sherlock Holmes? If not on Netflix, you don't subscribe, go and watch YouTube, you know, because it's a very famous character and they're very nice things. And this is what he does. He looks at you and he makes conclusions, and he's very accurate because he's very observant. And when I was in medical school, year one, my professor of physiology, as we were about to sit for our exam, told us, you guys, if you want to prepare for an exam, go to the cinema this evening. Sit outside the cinema, watch the people as they come out. And as they come out, make a diagnosis by the way they walk, by the way they look. I won't forget that, because it's really very illuminative of what medicine is all about. We make diagnosis based on our senses, and it can become very, very accurate. Okay, this is what is happening with this case as presented by your Professor Patrick Tan. And of course, I must thank Professor Tan for arranging this, and the faculty for allowing this session to go on, and of course the society for wanting to host this. I hope it works well. Okay, next, come. Hello.
Neck veins are prominent and distended to the mandible when the patient is sitting upright. The apical pulse is palpated in the fifth intercostal space, left of the mid-clavicular line. And S3 is palpable at the apex. S1 and S2 are diminished. S3 is heard at the apex. A grade 3/6 holosystolic murmur is heard, best at the apex. It radiated to the left axilla.
Okay, now I'll tell you something. When I first read this, I was very surprised to see that my friend Patrick has noted that S3 is palpable at the apex. I am now 1983 to now, almost 40 years a doctor, 30 years cardiologist, but I have don't recall S3 being palpable. It's a sound you hear, not what you palpate. So what did I do? I Google it up. You see, I Google palpable heart sound. And to my surprise, it is true. You can have palpable first sound, palpable second sound, palpable third sound, and palpable fourth sound. So I learned something. And that's why I like these sessions, you know, because not only are you learning, I'm also learning with you. And it is always good. And the more interaction we have, the more we can learn. So S3 is palpable and can be palpable. Now, to appreciate these things, what do you mean by the neck veins are prominent and distended? It means the jugular venous pressure is elevated. This person probably has edema, and there's too much blood in the systemic system. There's right heart failure. So it will present as edema or ascites, and you see it as the distended jugular venous pressure. And you're going to learn to distinguish the jugular venous pressure from the carotid pulse. I have a little slide on it. So when the neck veins are prominent, it's very important. This lady has right heart failure. Now be very careful, and please, when you approach a patient, look at the neck. I had a patient that was talking to me in A&E. She was quite well, no? And then so what do we tell them? Lie down, let me go and get my BP stethoscope, call the nurse. The fellow lay down, and within 2 minutes, the fellow became very breathless, had to sit up, panting away. You know? That's because the fellow is in heart failure and is badly autotonic, cannot lie down. Lie down only, the blood flows back, go into heart failure. And had I been careful and looked at the neck, I would have seen that actually this fellow is going into bad heart failure. So I learned a lesson, and from now onwards, for all cardiac patients, A&E patients, I don't lie them flat. No. I elevate the bed at 45 degrees. When I tell them to lie down, I lie down at 45 degrees, and the neck is what I look for first, so that I do not miss a serious heart failure that can get into pulmonary edema. I hope you remember this story. Yeah? But this thing of telling patient, lie down, I come back 5 minutes time. If you go and pass urine or go toilet, this can be a tragic thing in an urgent setting. Always look at the neck at 45 degrees. That's the classical position to look for distended neck veins. By the time it's distended to the mandible, when sitting upright, is very distended and very severe jugular venous elevation. Apex speed shows whether there is cardiomegaly. Fifth left of the mid-clavicular line is enlarged heart. When the apex is displaced, it basically means there's enlarged heart. And when the S3 is palpable, it's abnormal. All heart sounds should not be palpable. S1 palpable, loud first heart sound, think of mitral stenosis. That's a classical one, I remember. But if S3 is palpable, and S3 is due to ventricular relaxation. See, first heart sound, look, when the heart pumps and the mitral valve closes, first heart sound. Then mitral valve close, then the ventricle opens so that blood flows in, and then it pumps out to the aortic valve, and then aortic valve close, second heart sound. So lup dup, lup dup. S3 is after the heart pumps out through the aorta, the aortic valve close, and then the ventricle opens. First, the mitral valve opens. There's no sound when it opens. Mitral valve open, ventricle fills. So that's diastole. So when S3 is heard during diastole, after the second heart sound, which is the aortic closing, and then when the ventricle pumps out through the aorta, the aortic valve closes, ventricle relaxes, mitral valve opens, blood flows in. As it fills, this is what causes S3. And if S3 can be palpated, it means the feeling is abnormal. And feeling is abnormal means ventricle is stiff or ventricle is hypertrophic. Something is quite wrong with the heart. That's why the S3 is palpable. Now, S1 and S2, I've just explained what they are, the first and second heart sound. And of course, if S3 is palpable, it must be audible. Sometimes in tachycardia, because of rapid feeling, the S3 can be heard. But in this case, when it's palpable, it means it's very abnormal. And then the grade 3/6 systolic murmur radiate to the axilla is trying to tell you this lady has mitral incompetence. So this is what it is, elevated jugular venous pressure showing right heart failure. The cardiomegaly, apex beat is displaced. So whenever there is a large heart cardiomegaly, there are only two things. Is it volume that it becomes big, or is it muscle? If a chap is goes to gym, he does a lot of aerobic, he's very fit, like the long distance runner. His heart is bigger volume, or if he's a weightlifter, then the heart is of thick muscle. You look at the long distance runner, marathon fellow, he's always very thin, but he got a lot of volume, you see, that's why he can last long time. And you look at the weightlifter, they are not thin, but they are very muscular. So when the heart is big, it's either a volume problem or a muscle problem. And a palpable third heart sound is due to mitral regurgitation, because in mitral regurgitation, there is a volume overload, and so the feeling is too fast. You Google it up and you will find that a palpable third heart sound is due to abnormal ventricular feeling. A third heart sound is due to abnormal ventricular feeling, and if it becomes palpable, it means two conditions: severe mitral incompetence or left ventricular failure. And the way he describes grade 3/6 radiating to the axilla, the mitral incompetence is not mild, it's significant. So this is what you have, and all these physical findings strongly supports the diagnosis of heart failure, both left and right. Now, I put this up, look up in the universal gigantic online library. So, are these good times or bad times? You guys are doing medicine when we have 3,000-5,000 doctors every year, to pay money to do the course. This difficult time to be doctor or what? During my days, if I don't know something, I must go to the library. Now, if the library is poorly stocked, I can't find it. I have books, but they may not have the thing, you see. And how many books can you have How many books can you afford? Now you guys have a gigantic online library. You just go into the net, you Google, and you come out. It comes out. No? Like, what is the third heart sound? What is the first heart sound? Okay, wards are closed. You can't go to the wards. What can you do? YouTube it up lah. You can hear the sound and all. No? So, are these the best of times or are these the worst of times? That's the beginning of A Tale of Two Cities by Charles Dickens. He says, what? This is the worst of times and these are the best of times. This Thomas Friedman, a New York Times reporter, wrote a book titled The World is Flat. Like right now, the world is in a way very even because you have access to the things people in America, in China, in Russia, in India, everywhere they have, So it's up to you what you want to do. The potential is limitless, but so are the problems. That's why it's the best of times and it's the worst of times. But please use the resources available to you, and it can be the best of times. Next, come. Hello, next.
Examination of the lungs reveals dullness to percussion in both places with decreased excursion of the diaphragms, cause rhonchi and moist inspiratory crackles heard bilaterally in the lower lung fields.
So what does this mean? So when it is dull to percussion, when the expansion is reduced, it's pleural effusion. Then when you hear moist inspiratory crackles, what are these? These are crepitations, and crepitation means the alveolar has water. So when air goes through water, you get bubbling sound. This is what crepitations are. So there's alveolar water or alveolar congestion. Then you hear rhonchi. Now what is rhonchi? Rhonchi is narrowing of the airway. Rhonchi you hear in smokers because the airway has mucus, or you hear in asthmatics because during allergic reactions and during asthma, the bronchus becomes narrowed with secretion. So you hear rhonchi. But at the same time, in heart failure, because water gets into the pulmonary area, they will go into the alveoli, and they can also be around the bronchial area. So they can cause bronchial narrowing. So all these clinical findings are compatible with congestive cardiac failure. Congestive cardiac failure causes crepitations and rhonchi. But you must also remember, a pneumonia, a bronchitis can also produce something like that. So it is possible, but we have always been talking about heart failure. So basically, heart failure is, as they say, slam dunk in basketball, clear already. But you must remember at the back of your mind, especially in a lady who is febrile, could there be some pneumonia, some bronchitis? Next.
Examination of the abdomen. The anterior wall is round and soft. The liver edge is palpable and tender. The spleen is not palpable. Examination of the extremities reveal diminished peripheral pulses. There's a pitting edema of both lower extremities.
Right. Now, what does this mean? You see, if the abdomen is soft, he's trying to tell you there is no infective process in the abdomen, that there is no cholecystitis. A gallstone cholecystitis can precipitate heart failure. There is no severe ascites because it will be distended heart with fluid. So he's trying to tell you that liver edge is palpable and tender. What is he trying to say? There is liver congestion. So this is not just a simple left ventricular failure. There's both left and right ventricular failure. What about spleen not palpable? Is that important? Yes. There's no severe sepsis. There's no portal hypertension. Now, if there is a liver disease, portal hypertension, the spleen should be palpable. Severe sepsis, bacterial endocarditis, the spleen will be palpable. All these not present. Now, what about diminished peripheral pulses? This means peripheral vascular disease, that the circulation to the lower limbs are blocked. Now, this is very common because the circulation is universal. Blood flows to the head, to the heart, to the legs. So when a part of it is blocked, the heart is blocked, the head can be blocked, they can have stroke, and the lower limbs can be blocked. That's why the lower limb pulses are less. And then finally, there's pitting edema. Why pitting edema? Because right heart failure. That's why right heart failure, that's why liver enlarged and congested, and that's why jugular venous pressure elevated. So essentially, this man has hepatomegaly and peripheral edema showing right heart failure. There's also peripheral vascular disease, as is very reasonable for someone who is diabetic and hypertensive with a previous heart attack, and no bacterial endocarditis or portal hypertension. So you can see that every part of the clinical workup has a meaning to it, and your mind works that way. Every time you read, you hear, it's working. What's the problem? What's the problem? Next, now investigation. Come.
We see the hemoglobin shows 16.4 grams per deciliter. The hematocrit is 40%. Leukocyte count is 84,000 per millicube with normal differential count. The platelet count is 290,000 per millicube.
Okay, generally this is all normal, you see. This is about all normal. But what else do you need? Well, you need the erythrocyte sedimentation rate. ESR is very important test to know whether there's some infection or inflammation going on, both of which can lead to heart failure, precipitate the heart failure. You need cardiac enzymes or troponin to know if there's an ongoing heart attack. And this is heart failure. In heart failure, the thing you must do now is the BNP, B-natriuretic peptide, because it is elevated even if people do not have symptoms of heart failure, and it can show severity of heart failure. And looking at normal leukocyte and platelet count, there is no severe infective process. So the temperature mildly elevated, probably not important. Next. Come. Hello.
Doctor? Yeah,
Yes.
the glucose level is 112 milligrams per deciliter upon non-fasting state. The blood urea nitrogen is 33 milligram per deciliter. Creatinine 1.6 milligram per deciliter. Sodium 132 milliequivalents per liter. Chloride 93 milliequivalents per liter. Potassium 4 milliequivalents per liter. Bicarbonate 23 milliequivalents per liter. Total bilirubin 1.9 grams per deciliter. Direct bilirubin 0.3 milligrams per deciliter. Total protein 5.8 milligrams per deciliter. Albumin 3.1 grams per deciliter. Urine specific gravity 1.032. 1 plus protein and hyaline class present.
Okay. Now glucose. This lady is diabetic. Glucose of this is obviously can be normal, can be abnormal, but you need more tests. You need A1C. A1C will tell you if it's say above 6.5 is diabetic. If it's above 7, not great control. Then you need more when you have more time, proper fasting sugar and 2-hour postprandial. Fasting sugar, normal people should be less than 6. 2-hour postprandial, normal should be 2-hour postprandial, normal should be less than 8. Diabetes fasting is more than 7. 2-hour postprandial is more than 11 for diabetes. And the conversion from your 100 over to 6, 7 and all is by a factor of 18. So you need proper tests to know more. And with this kind of a renal profile, there's mild renal impairment, a slight elevation of the creatinine and blood urea nitrogen. Look at the sodium, a bit low, not too low, but maybe she's on some diuretic. That's why it's low, because you need to get rid of the water. And when you get rid of water, you get rid of salt also. And then look at the liver function, maybe mildly elevated bilirubin, but you really need the liver enzyme, alanine and aspartate transferase and alkaline phosphatase. And for the urine, there is protein in the urine suggesting diabetic nephropathy. But you also need microscopy to look at cells. Is there some red blood cell which can occur in diabetic nephropathy, but also in urine tract infection? Diabetes are very prone to infection. Is there mild urine tract infection? You need to know. Next. Hello.
X-ray mark prominence of the pulmonary vascular shadows, bilateral pleural effusions, increased haziness and decreased radiolucency of the lung parenchyma, bilateral, and increased transverse diameter of the heart.
All right. Now, if you can, go and please look at the video in my YouTube about my CCF lecture, because I showed pictures of X-ray abnormalities. This is heart failure. There's clear-cut, prominent vascular shadow, pleural effusion, haziness, and enlarged heart. So there's CCF. Now the thing about it is there's no localized abnormality. It's bilateral, basis, central. So it's heart failure. There's no active pneumonia. And this I teach you is a secret. We are all supposed to be specialists in our field. So when you do an X-ray, the specialist is the radiologist. And as young doctors, after doing X-ray, you must, corner down the radiologist and squeeze him for an answer, yes or no. Is there pneumonia? And most people will tell you maybe, can be, but the good one will tell you unlikely. No pneumonia. So these are the things you want to get and you want to learn. Yes or no. Too many people hedge their bets. I know that I have to take a stand. I take the stand, it may be wrong, and I will learn. But if I don't make a stand, I cannot learn. So you also need an ECG, and you need to know whether there's myocardial ischemia. So if you ever show a cardiologist an ECG, you ask him, is there infarct? Is there ischemia? So that there is a reason why you do something, and you want to be clear about it. Actually, this chest X-ray is very important because remember, we said there could be bronchitis, pneumonia from the auscultatory findings. There's a bit of fever. So we always think of infection. So it's important to know, got pneumonia, no pneumonia. It doesn't look like it from this report. Okay, and then I will now finish up by telling you, as we approach a patient with heart failure, it's very important to get good symptoms, look at the signs, and remember two things. There's always an underlying cause and a precipitating cause. The symptoms, remember this lady had fatigue, exercise limitation, weight loss, anorexia, depressed. These are all symptoms of heart failure, of forward failure, because there's not enough perfusion to the gut, to the muscles, to the head. She can get all these things. So this is symptoms of forward heart failure. And then you can cough, you can become dyspneic on exertion, because these are symptoms of congestion, of backward failure. The left heart fails, there's congestion before the heart, as in the pulmonary area, and that's why you get dyspnea on exertion and cough. Orthopnea, because the heart can't pump out the extra blood when you lie down. Paroxysmal nocturnal dyspnea, because you strain your heart in the middle of sleep, 2 to 3 hours into sleep, and the heart can't take it. You get it congested. That's why you get this. Peripheral edema due to right heart failure. And you can have abdominal distension, hepatomegaly, and then even ascites from right heart failure. And the signs, of course, they will have a tachycardia. It may be irregular. And like I said, if it's irregularly irregular atrial fibrillation, or basically regular with some irregularities, and that's the ectopic beat. And then you have to know about pulsus alternans, which I'll show something afterwards. It's one big, one small, one big, one small. Edema or elevated JVP shows right heart failure. You feel for cardiomegaly, that's the heart is enlarged, volume overload or muscle hypertrophy. You look for sternotomy scar, previous surgery, bypass, perhaps valve replacement. You listen for third heart sound. Listen for murmur. That can be the main problem, or that can be secondary to cardiac dilatation. You look for lung crepitations to show pulmonary congestion, bronchi to show airway narrowing, and of course hepatomegaly. These are the signs that you have to look for. Now, this is a slide from my lecture of the signs you have to have. And you see the case that Professor Patrick Tan did, everything is in it, and it's what is going to happen in your real life. So medicine is funny, if you know your stuff and are good, it gets more and more interesting. If you don't know your stuff, it's very stressful and distressing because you don't know where you are, And like Sherlock Holmes and the police inspector. Police inspector don't know anything, life not so nice. Sherlock Holmes knows everything. So if you do medicine, try to be Sherlock Holmes. Now, if you don't like these things, then I will tell you a little bit of story afterwards. This is pulsus alternans. You see, when you feel a pulse strong or weak, it depends on what you call the pulse pressure. Difference between systole and diastole. The pulse pressure gives the volume that you feel at the pulse, the radial pulse. And you can see one big, one small, one big, one small, one big, one small. And this is called pulsus alternans. You want to distinguish it from pulsus paradox. Pulsus paradox means the volume gets smaller when you breathe in. So it is indicative of lung disease. When they breathe in, the volume drops. When they breathe out, the volume goes bigger. That's called pulsus paradox. So you have to time it, tell them to breathe in, and in fact, as they breathe in, a few beats will be smaller. Breathe out, as they breathe out, the beats become stronger. That's pulsus paradox. Alternance, whatever you do, one big, one small, one big, one small. So you got to time it to try and distinguish the two. And then, of course, the jugular venous pressure, very important. Like I said, lie them down at 45 degrees, look at the neck, and you learn to distinguish the pulsation of the external of the jugular vein from the carotid. Carotid is single pulse. It's a arterial collection, pulsation, single, strong, and you can feel it, you know. The jugular venous is double pulsation, and it's venous, so you can't quite feel it, and it's occludable. Put your finger at the bottom of the neck, and the jugular venous pulse will disappear, you know. And then, of course, you want to try and look for the internal jugular because it's less easily compressed. Sometimes muscle things can compress the external jugular and give you a wrong idea. Now, there is a look at this, 10th December 2020. On the 10th of December 2020, in the famous New England Journal of Medicine, they did a video on examination of the neck veins. Such a simple, basic thing, and the journal found it important to produce a video to educate people about examination of jugular venous pressure. Something you all learned, and I'm sure the editors learned as a medical student. This is a perennial tool, you know, a tool that is useful for generations and for centuries. So remember, in heart failure, there's always an underlying cause. Is it hypertension by itself, ischemic heart disease, heart muscle problem, inherited like cardiomyopathy, infective, toxic like myocarditis? Is it arrhythmia giving rise to as the heart, a problem giving rise to heart failure, a valve problem, something they are born with, infiltrative muscular disease? Is it due to cytotoxic drugs? Due to analgesics, alcohol, due to hypoventilation, lung disease. Lung disease can cause heart failure, obesity, and metabolic conditions. Anemia, thyrotoxicosis can cause heart failure. And then, of course, what precipitates it? The precipitating cause. They don't take medicine, they eat too much, suddenly become hypertensive, they get a heart attack, acute active ischemia, some valve become infected, sudden arrhythmia, infection, very important. They take medicine that precipitate the heart failure, drink too much, don't do dialysis, and other things. So underlying cause, precipitating cause. So remember, when you see a patient, is heart failure present? How severe is it? What is the underlying cause? What is the precipitating cause? And with this, I end this now and then ask you for questions. Come. Got any question?
Doctor, I have a question.
Yes.
So regarding heart diseases, how is a patient with history of smoking significant?
Oh, smoking very significant because number one, smoking is one of the most common underlying risk factor for ischemic heart disease. If you smoke over decades, the arteries of the heart tend to narrow. And narrowing of the arteries of the heart reduces blood flow to the heart, causes weak heart, causes heart attacks. Smoking leads to that. So smoking is very important as a cause, underlying risk factor for coronary artery disease. Number two, smoking leads to lung disease. When you have lung disease, you don't get enough oxygen. When you don't get enough oxygen, your heart muscles also don't get enough oxygen. So lung disease, hypoxia worsens myocardial function, can lead to heart failure. So very important. Smoking, very bad. Nothing good about smoking. Next.
Doctor, I have a follow-up question. Can we say the same thing for vaping?
Can say
what?
what?
Can I say the same thing for vaping? Because a lot of people are vaping nowadays instead of smoking.
What safety for? I can't hear your what?
Doctor, I'll type it in the chat box for you, please.
Yes. Well, no, okay, now this one I don't know how to see, you know. Hello, can you all, I can't hear what she's trying to say.
She said about vaping.
Vaping, doctor.
What waiting? Spell it out for me.
The electronic
Vaping. Oh, vaping. V-A-P-I-N-G. Okay. Vaping no good. Okay, vaping no good. Why vaping no good? The best is don't do anything. You see, when you vape, you are also putting into your chest, into your nose, and into your lungs. No good, no? Firstly, people put a lot of things inside, no? These people like to smoke, like to try things. So that people who smoke, then smoke cannabis. People who vape, put things in, they put a lot of things, and then they become very sick, pneumonia, and can die. They put some of the things they put, it may not be the actual thing. They put cannabis, but it's the oil, The oil then gets sucked into the lungs and they get into a lot of trouble. So, and then if you take in smoke, nicotine, in whatever way, vaping, pumping, patching, is never as good as if you are free. So, it's not good. Any form of this kind of thing is not good. Difficult to give up, but not good. You go and Google about it. Vaping quite interesting. A lot of new diseases was found from vaping. Because this oil goes into the lungs, and suddenly they find young people come with bad pneumonia and things. So it's bad news, vaping. Okay, next.
Doctor, I have a question. So
Yeah.
I want to ask if there is many methods or manual that augment S3 to be palpable.
Augment what? Augment artery.
S3.
What do you about?
S3.
Huh?
S3.
Oh, S3.
S3.
Okay, no, okay. Now you no need to augment because S3 may be normal, may be abnormal. In the tachycardia, the feeling is very fast. You can hear S3. That means anemia, you can, excitement, you can. So no need to augment one. All you know is that there is a third heart sound. And sometimes S3, very hard to tell whether it's S4, especially it's fast. You see, it's like that. Lup, dup, dup. Lup, dup is S1, S2, dup. S3 is closer to S2. Lup, dup, dup, lup, dup, dup, lup, dup, dup. That's S3. S4 is top, dup, dup, top, dup, dup, top, dup, dup, top, dup, dup. It's before the fourth. So not easy to hear. Go Google and try and listen. And then if you can hear that there are three sounds, you're very good already. It is only one part of your clinical assessment. So don't take one part too seriously and concentrate on it. And then sometimes people present as there's a gallop rhythm. Like that. So don't go and augment all these things. Yes, next.
Doctor,
Yes.
can I know how important is the brain natriuretic peptide assay in this case?
Important. Anybody with heart failure, it should be done. The problem is, it's I think not widely done in the Ministry of Health because we are not that rich a country, and it's elevated, and sometimes it's elevated even in healthy people. Healthy in the sense that they have heart failure, but they don't know. So there's some form of stress and strain. So the BNP will be high, but he doesn't feel it. You see. So it's important to do. You read the books, they'll tell you. And if it's high, even when he's well and discharged, it's not so good a prognosis as if it has normalized. So the answer is theoretically very important. Practically, maybe we don't do it so much. I don't do it, for example. I think ministry doesn't do it. Not that I don't do it all the time. I don't do it because it's not cheap, you see. Something like that. Yes. Next.
Good afternoon.
Doctor, I'm so sorry.
Yes. Never mind.
Okay. Doctor, in your slides just now about the precipitating cause for the heart failure, the last cause is alcohol withdrawal. May I know how is it become the precipitating cause?
Because very stressful. You give up alcohol. Now, for a guy who is used to alcohol, give up is very stressful. Just like for a smoker, you tell him to give up, it's like a drug addict. Now, why does a person smoke? A person smokes because it gives pleasure. And after smoking, the body gets used to the nicotine. So it becomes a physical dependence. When you stop a smoker or alcohol fellow, the physical dependence takes about 2 weeks to go away. So for 2 weeks, they'll be bad, like a drug addict. They'll like have running nose, feel out of sorts. So 2 weeks, there's physical reaction. And of course, you're under more stress when your body physically used to something is deprived of that. So there's a physical stress for 2 weeks. Now, these 2 weeks, most people can overcome. 2 weeks is a short time. MCO, 2 weeks, we can all do it. But what happens? It becomes prolonged. That one got problems. See, so the reason why a smoker has stopped and then come again is because of personality and habit, lifestyle. So they smoke because they smoke during certain times when they are stressed, when they go toilet, when the wife next too much, the husband goes out to see girlfriend. I don't know. Then they start smoking. Is it? So it is a lifestyle problem. Or when friends smoke, or when friends drink, then they drink. So there are two parts to this addiction problem. One is the physical part, but the other is the lifestyle part. And that's why drug addiction, you cannot stop it. That's why, I don't know if you know, but I was in the courts in the first MCO, and I didn't know the rules and all, and I got not nice experience. But when I went to the courts, almost everybody was drug addict, drug addict. So it's very difficult because they keep going back. Why do they go back? It's personality, it's lifestyle. It's very difficult problem. Yes, next question, yes.
Yes, I want to ask about
That was not drug addict. I got walking home after going to the park and then got into trouble. Yes, next.
Okay, so I want to ask about the current situation about COVID-19. I want to ask, how can a patient who has heart disease have higher mortality if he or she gets COVID-19?
Okay, COVID-19 is an infection. No? In any infection, the weaker your body is, the worse you are. No? So no need to talk about COVID-19. Simple urine tract infection, simple diarrhea. If your kidney is weak or your heart is weak, you can get into a lot of trouble. I have a patient with heart failure, and what got him into a lot of trouble? He got into septic shock. Why? Diarrhea. Because when he got diarrhea, his volume dropped. Then he keep taking his medicine. He become hypotensive. When he become hypotensive, he go into kidney failure. So no need COVID-19 in any form of an infection or a stressful situation. If your underlying body is weak, your organ systems are weak, you are in trouble. So this is bad news. It's not just COVID, COVID is just one of many that we have gone through. In my time, I saw SARS, and then we had H1N1, and this is the third one in my 40 years as a doctor. And the last one, H1N1, was quite dramatic. There was a nurse, a male nurse, who is quite plump, and he plays volleyball. He's very strong. He play volleyball better than I. He can spike better, and he's big size. But you see, he got H1N1. And obesity is a risk factor. They can't breathe. When you are obese, your abdomen is huge, and you can't expand the chest as well as a thin person. So he died of H1N1. Poor fellow, he just got married. So it's not just COVID. It's any respiratory condition, any disease. When your body is not healthy, it does badly. Okay, and then COVID is a very funny disease. If you want to go and listen to my tips on COVID, and they are asking me next week to do another one, you can ask Ganesh, and I ask this guy, my friend, if he will invite you. This COVID causes a immune reaction. The body senses the virus and then produces antibodies that attack other part of you. And it is a common cause of heart attack and strokes. In fact, COVID is almost considered a cardiovascular condition because a myocardial infarction very common. And then post-COVID, they get myocarditis, So it's a very funny disease, and certainly not everything is known. It's COVID is very interesting. It's almost an autoimmune infective condition. Okay, next.
I have another question also. It's my own.
Okay.
So I want to ask regarding the YouTube videos, right, that you put up, and you said about ACEIS, the drug, is better than ARBS.
Yes. For heart failure, yes.
For what I knew is ARB is better than ACEIS because of they messes with the bradykinin mechanism and also the drive cough.
Okay.
So why is that so?
Yeah, of course I'm right. Okay, let me explain. Wait, let me explain to you. Okay, ARBs are invented after ACE. And the reason why they were invented is because ACE caused cough. And ACE caused cough because of what you just described, the bradykinin thing. So ACE cause more in us Asians, 30 to 50%. So it's a big problem. You start people on ACE and then they start causing cough, and that's a problem. So almost everybody use ARB. And then there are many ARBs in the market. No, many companies produce ARB. There's a lot of promotion. So everybody thought ARBs was better. Yes. But in the last 5-10 years or so, if you look back at the data, now there is no trial that compares ACE with ARB. But if you look at the ACE trials, that means ACE placebo and ARB placebo, you find that the reports of adverse events in the ACE placebo is lower. That the ACE placebo trial produced less heart attack, less heart failure, less stroke, less death than the ARB placebo trial. And this is something I personally went to do with GH people and with Penang Medical College people. We produced a paper that looked at 6 ACE trials, 6 ARB trials and 4 ACE trials. Clearly, the ACE trials were less cardiovascular events, were better for the patient than the ARB trials. But there's no comparison, ACE versus ARB. There's no such trial. So this is a fine point that I mentioned because I think most people will accept it. And even in the clinical guidelines now by Malaysian societies, they mention it. Even in the hypertensive guidelines, they mention it. Use ACE first, and if they can't tolerate, use ARB. Okay. Yes.
Okay, thank you very much.
Thank you. Thank you. Any points? Any point?
Yes, sir.
Okay. Yes, come. Very good.
So,
come.
What is the immediate treatment for this patient if he comes to the emergency room, sir? Can I know that, please?
This one diuretic. Okay, treatment is a long story lah. Treatment diuretic, get rid of the fluid. This lady is breathless. You have to use diuretic, get rid of the fluid. And then you have to use intravenously to make it effective. But you got a problem, BP a bit lowish, So you got to give diuretics. You got to give oxygen. You got to admit. Then you may want to give nitrates, intravenous GTN to titrate it to improve myocardial perfusion, to venodilate. Nitrates are venodilators, so they reduce backflow to the heart, they make them better. But don't ask questions on treatment because you will not be expected to know. And you will learn as you practice. Because right now you have to pass exam, so that's one thing you have to all think about. I do exams for people, I do final years, and I do MRCP exams. So you want to pass exam, right? And treatment is not an important part of what you should be into now. Yes. Anything else? Okay, if not, come, I want to do this. Hey, how do I? Okay, I close it. Okay, so now this is a real problem. We do real problem. How do I go back? Now I can't go back. How do I go back? Why? I can't go back. What this is? Okay. Anyway, my first slide said, is medicine a good profession today? And this is from the MMA, and you can see overwork, unhealthy, dangerous environment. Can't hear me? No, that was some time ago. Can you all hear me?
Yes,
okay. That was some time ago. Okay, so you are all overworked, you are unhealthy now, COVID everywhere, unfair pay, some of you get contract, some of you permanent staff, not same pay, a contract don't know get or not, people bully you, you got all sorts of problems. Today is 2021. Medicine is a very stressful, bad profession. Is it? You see, I got problem, my friends. I can't move my thing, Why like that? What do I have to do? I can't move it. So maybe I should. Can I stop for a while and then I reshare again? Is that correct? I don't understand why. So I have to try and do something. Stop share. So now I want to share again. There you go. I don't know why like that. So share. Okay, so I'm back. Let's see whether it will work. Cannot work also. Why like that? Let me see. Pause share. Okay. Resume share. Cannot. There come already. Okay. So but look at this. See now we talk about this. You see, 2021, 20 years ago. This is a BMJ survey, my friends. Look, are doctors happy? Very unhappy or unhappy? UK 2/3, Spain, Belgium, everywhere, like India 70%, Hong Kong 2/3, Malaysia 50%. Happiest are in Pakistan, 1/3 only. Now, this problem of unhappiness in medicine is nothing new. So no need to get too depressed. You work long hours, you underpaid, you got a lot of problem. It's like that for a long time. Now, why? Same thing. 20 years ago, they said they're overworked, underpaid, not supported. No control. Then society lost its way, Whether you want to say government, politician, or whosoever, lost its way. And then you are the ones now at the front line. And then, media scolding us. I see politicians are a problem. Health service, no good. Status dropping. So we doctors face a lot of difficulty and can be very unhappy. So let's talk about job and money, because money, I think, in life nowadays is very important. And then, of course, what's more important is happiness. What does a doctor earn? A doctor earns enough. You compare yourself with a teacher, with an accountant, you will be comfortable, you will be secure, but you cannot match those in certain professions. You cannot match the businessman. You cannot match the share trader. You cannot match the financial analyst. Why? Because we have to spend time to earn our money. Even you're a great surgeon, there's only 24 hours and you can't operate the whole day. So you must understand, you can earn enough, but you cannot earn a lot. So if you want to earn a lot, medicine is not for you. I think that's the first important thing. I've gone through 83 and now almost 40 years. Have I enough? I have enough. I stay in comfortable place. But to stay in comfortable house, I drive Proton. I drive the good Proton, the X70. So it's like that one, but we have enough. More than enough compared to a lot of my friends, more than enough. But are there friends who are wealthier than I? Of course. And my patients wealthier than I? Of course. So you must position yourself to know what you are in for. You want money? Please, I think, go into financial line. That one, or go into business. The business or medicine, that one maybe can earn a lot of money. So this one, no. Now, we always say we are overworked. Like today, I'm working, But you look at me today, I don't think you think I'm working. You see, obviously, I'm quite happy talking to you all, trying to make your life happier. You have to change the pain of work to the pleasure of action. You must learn to like medicine. That means when the patient tells you a story, you're interested to know more. You're interested to know about the patient. You're interested to make a change, to try and do something good in this world. Then you can change it to pleasure. Then it no longer becomes work. And Warren Buffett is an investor, very famous one. He wrote a book. The title of the book is Tap Dancing to Work. Dancing to work. He said every day if you wake up and you go to work, it's like you are going to dance like that. And that is the job you should look for. This guy, for some, playing share market is so stressful, looking for business. For him, it's his joy and pleasure. And he's now close to 90 and still going, So you must change pain to pressure. Now, how not to be overworked? You see, it requires perseverance. So you change it to pleasure. And for it to be a pleasure, you must be able and you must be competent. Now, this one you cannot lie. Remember, I showed you the thing, the more competent you are, the more able you are, the more you enjoy something. It's like that. Why do people do certain things? Why do you build up hobbies? Why do you do certain things sometimes bad for you? Because you are able and because you can. Then the more you go into it, the more you like. See, why do people become sugar daddy? Why? Because they have money, they like to buy things, buy car, buy house. Now they buy people. So it's like that. So if you want to be into doctor, you've got to ask yourself, what is it I'm good at? And then you've got to acquire ability. Now, acquiring ability is never easy. It's just that you learned how to read and write. You learn to write, your writing no good. During my time, we used to handwrite. I don't know whether you handwrite. Then you writing no good, got hit on the, your teacher come, ruler and knock you. But you got to learn, you see. So everything requires you to learn. So you got to put in the effort. You got to suffer a bit. And the Chinese say, 吃苦, eat bitter. You have to take bitterness to acquire ability. But everybody has ability. You got to find out what is your ability. And once you acquire the competency in a line of your ability, you will like it. Life is like that. That's why people paint. That's why people write song. Why are the Beatles doing what they do? And sometimes some of these, Mick Jagger is 70s already can give concert and all, because he likes what he do and he's good at what he do. So this is the way we have to progress. So you want to be happy, successful in medicine, choose a field you're good in, choose a field you like. This is a quote from a director of a movie that at one time was the top grossing movie. He said, I didn't expect I can touch people so much that when you put your heart and soul, people know your sincerity. Try your best, people appreciate you. And you have to pay attention to details. Now, this is the problem today. I see very many people very careless. Whatever work they do in bank and all. Once I asked to transfer money, fellow missed out one number of my account. I got the money lost. So it's very distressing when people don't pay attention to details. And look at what he did to film a good movie. He waited days just for the right sunlight. But in the end, he felt it was worth it. So if you like medicine, you do medicine, I assure you it's worth it. You ask me now, is it worth it for me? I tell you yes. I think you look at my face, it's yes, because it's a fun job. It's a good job. Look at this girl, no? She's 19 years old. She hates scarf wearing. She's a girl, no? And she wrestling. She fight with people. No? But she enjoyed her success. She beat 4 men and became champion. At 19, so small size, you think easy for her. Very difficult, man. Some more woman, no? And woman beating up men. You think people nice to her. So you can do it. If she can do it, why can't you, you see? And then look at this story. This is from a book made into a Netflix movie. This boy was too poor to attend classes because they're too poor to pay tuition fees. So what did he do? He went to the school library to read. And then the village had a drought. And because crops couldn't grow, they had nothing to eat. Very, very serious. There were riots. The family was robbed. The family was broken up. They had nothing to eat. But what he did was he built a windmill. With the windmill, they were able to power electric pump to bring water to the fields to grow their crops. So he saved the village. Now, this is a true story, and so it tells you that whatever circumstances you are under, you can make it. If he can make it, why can't you? You see? So don't worry about COVID and don't worry about 5,000 doctors a year and all. You interested can do it. And these are two sayings or two things I've come across that I want to share with you. One is a song by Kenny Rogers. Please go and Google and listen to it. It's a very nice song, very catchy tune. Where it says, every gambler knows the secret to survival is knowing what to throw away, knowing what to keep. Because every hand's a winner and every hand's a loser. And the best that you can hope for is to die in your sleep. Now, you must know what is good for you, what you have to keep, who you mix with. You must know what to throw away, what you cannot do, what company you cannot keep, what you should not involve yourself in. And every life, no matter how good or how bad, you can turn out worse. No matter how good or how bad, you can turn yourself better. It's with you, you see. And then in the end, all of us will die. So while you have the chance, you are not dead. You know that you can make a difference for yourself. But you have to choose and you have to be wise, You must know and you must learn. You see, gambling is very interesting. Poker gambling they're talking about. In poker, they have competition and the same people win. Just like, this tennis, this Australian Open, it's the same people. Djokovic is there again. Why is it the same people? If it's a game of chance, cannot be same people. But poker is always the same people who win. Because it's a skill, it's a concentration, and it's knowing all these things. So time immemorial, good doctors is there. The the rules, the guidelines are there. It's for you to decide if it's for you. That's all. And then this one, Charge of the Light Brigade by Alfred Lord Tennyson, an English poet. It's about soldiers told to attack a certain area, almost certain death. Forward the Light Brigade. Was there a man dismayed? Not though the soldier knew someone had blundered. The general made a mistake. Theirs not to make reply. Theirs not to reason why. Theirs but to do and die. Into the valley of death rode the 600. Now, in a way, we are all like that. You say government right or not, they say this right or not, what for you say all these things. They tell you, you are here, you have to obey. Of course, you obey to protect yourself, you obey not to do worse. But if you keep questioning, they no good, they right. What's the point? You have to be wise in your choices. You mustn't get angry and you mustn't hate. And you mustn't blame others. You have choices, is it? And you mustn't blame things beyond your control. Why you say COVID now? COVID is COVID. It comes, we have to face it, you see. And then if they do MCO or RMCO or CMCO, they do, we have to follow. Because you don't follow, you get yourself into trouble. So sometimes you've got to be very careful to do the right things for yourself in the circumstances you face. Because every circumstance you can come out winning, and every circumstance you can come out losing. Make sure you win, you see. That's, I think, the answer. See, this is a Scottish surgeon who came to Penang, 1802. He draw flowers, plants of Penang. This is Neo Chin Boon. Is he still teaching you all? Dr. Neo Chin Boon, is he still with you?
Yes, sir.
Yes, doctor, he's still.
You tell your Professor Neo Chin Boon, say Ong Hian Teck showed his painting. You see, Neo Chin Boon, few hundred years later, do bird painting. So doctors are like that, They like to observe nature. They like to contribute to nature, Look at this guy, 100 years old. He's an obstetrician that is still working, because he enjoys the work. Look at this girl, Malaysian girl, won an award for cancer research. So she gets a chance to go to Cambridge, I think it is. Cambridge Fellow, I think. I don't get a chance to go to Cambridge. I'm in private practice in a small clinic, but I can still write papers. This is an American journal, this medical journal of Malaysia. With the cards that we have, the hand that we have, we do the best utilizing it to produce something. And just like other people can produce, we can produce. And if we are happy to produce, that's enough. That's the pleasure it is. So read these things. And so I end by telling you that throughout history, we doctors are interested in society. That's why I'm doing this today, interested in you guys, the future, you see. We cannot be very rich. We'll have enough, but hopefully we are remembered for the good deeds we have left behind. And is medicine good? I think yes. If you like it, it's very good because you got adequate material life. You got a good name, You are the good guy. You are fighting COVID disease. You are the good guy. If you are a politician or a lawyer, there's always the other side. This party, that party say you bad guy. That one becomes very debatable. And every day what we do is meaningful, it's helpful for those who need us, So medicine is very, very wide in its options. Now, if you decide you like medicine, then you can always go into one area. Is it clinical medicine where you practice as specialist or practice to look after family? You don't like people, there's still public health. There are the preclinical sciences. You can be into academic teaching, you can be a researcher, you can be an inventor. And now, this AI and medicine, the need for doctors to be away from patients, the need to use AI and 5G and all to long distance medicine is very, very important. You see, the latest vaccine is mRNA using gene manipulation. They have now used it for cancer. A report just came out. What about stem cell? What about targeted therapy where they try and change your gene to change your disease? All these are very, very new things, important, that you people can go into. You can be an administrator, run the Ministry of Health as well as it should be run. You can do that, You can be a medical entrepreneur, make a lot of money from medicine, and you can be like Dr. Mahathir. You can be like the medical advisor of the Prime Minister now, this doctor who was from Mercy Malaysia. Because of Mercy Malaysia, she found her calling and her fame. So it is very, very wide in what you can do. But whatever you do, you must be able. You must be competent and you must love it. Then only you can be successful. And if you find that your ability, your competency and your love is not in medicine, then I think you have to move away. When you move away, it's between you and your people, but it's not fair to yourself that you do something for the next 30, 40 years, a line that you do not like. But if you like, as I like, medicine is very good. And you know, if you like to eat char kway teow, cook char kway teow, you set up char kway teow store. You don't ask how many char kway teow stores are there in Penang. You know, let people cook their char kway teow. You cook better one, and you will be happy. You see. And with that, I thank you and wish you good luck. Okay. Yes. Any questions? Any points? 1.5 hours. I don't know. Yes. Yes. Anything else to say? Huh? If not, I leave you now. Huh? Okay. Thank you. Bye-bye.
Thank you.
Okay. Bye-bye.
Thank you very much, Doctor.
Bye-bye.
Thank you very much, Doctor, for such an insightful discussion.